Okay, thanks very much. And as with all of the others, thank you very much for the invitation to be here and the opportunity to discuss this, which I think is it's a fascinating and critical issue. So just what I want to acknowledge right now is that this, and I suppose like everything else, and I gather talking to Pat earlier today, we accept in this meeting that everything is built upon something else. So what would need to be done to achieve a Canadian pain strategy? We have to get to a priority status in governmental decision making. You get there by both having a problem, but nobody in government is interested if you have a problem because everybody has a problem. You need to fit into the current policy stream, and you need to tap into the politics stream also. You need a policy entrepreneur who can bring your case forward, knows who to talk to, whose phone calls other people will answer. And you need political champions at all of the decision-making levels. For example, the Canadian Strategy for Cancer Control, a remarkable piece of work that unfolded over, as I understand it, about 10 years. Many of the same goals. You could plug chronic pain in wherever it says cancer here, and we would have exactly the same goals. They came up with a document about, it's probably 10 or 15 years ago now, but they had a governing council that came up with a 5-year business plan, and a variety of inputs were made into that. It was revised substantially before it went forward. I've been told this is an appalling slide. It is an appalling slide. The critical number is in the bottom right-hand corner, $260 million over 5 years applied to the problem addressing cancer. How do we treat cancer? How do we diagnose it? How do we most effectively treat it? That is what one describes as the big ask in politics. And that was for a variety of things. That was for coordination of diagnosis, treatment across the country, research. It was for something they called the cancer patient's journey. How do we ensure that best practice occurs everywhere? And we've heard about that in chronic pain. The cancer control workforce. Do we have enough cancer researchers in Canada? Do we have enough pain researchers? We've heard that we have the best pain researchers in the world, bar none, in Canada. More key papers have arisen out of Canada per capita than any other country in the world. Are we training enough to continue to have that kind of impact? So what did we learn from talking to the people that developed that cancer strategy? First of all, it takes time and effort. You need a lot of stakeholders. You have to include patients because patients vote more frequently than their caregivers do. I have something like 400 patients that see me various times over my chronic pain clinic in the course of a year. That's 400 votes, not my one. So you need patients for a variety of reasons, also because they give you the best ideas. You have to have people with a consistent voice, so you can't have, there's a brilliant piece at the end of Monty Python's Life of Brian when all of the groups purporting to solely represent positions present themselves around the cross. But you have to have people speaking with a consistent voice. You need data, you need a feasible strategy, and you have to incorporate Health Canada in particular for a health issue. So this has happened before also with respect to pain. Australia has a national strategy. A lot of the activity for that came from a gentleman named Michael Cousins, who's a past president of the International Association for the Study of Pain. He had has still, because he's still active in clinical activity as well as research and politics, unique ability to bring people together. In Australia, it was important. They could quantify the burden. They had, at the time, established pain medicine and palliative medicine as independent medical specialties, so they were building the body of clinicians. They had a program of health reform. It aligned with their national health and research agendas, and it fit in with the primary health strategy, and the state governments were fitting in. So where are we in Canada? In 2011, some of you may be aware that a document was presented actually in 2012 it was presented. It was finalized in 2011. And it was presented at Parliament in 2012, and it did not take off. was broadly endorsed across the country. Patients, clinicians, researchers, and they were supporting the call for a national pain strategy. There was a national pain summit the year before, or 2 years before, at the meeting in Montreal. The IASP made a declaration about the importance of pain. In 2012, we had hoped that the Federal Minister of Health would announce support for this. That did not happen. And in 2013, there was no Federal Minister of Health announcement before funding. So how do we address that? What's the next step? A couple of things have happened. You've heard about the Chronic Pain Network, an initiative of the Strategies for Patient-Oriented Research. And actually, you saw in the remarks from Minister Taylor in the introduction in this the shiny pamphlet about today's meeting that $85 million in the past 5 years has been allocated to pain research from CIHR. CIHR's annual budget is $1 billion. So over 5 years, we've funded the Chronic Pain Network, but that's really a startling stride forward in many ways. And you'll see the areas that we have focused our efforts, but the vision is to change the way pain is managed in Canada. We have a variety of people, including a formal patient engagement process. And we've taken the opportunity to do a couple of things. One is to create something called the Canadian Pain Care Forum, which currently has about close to about 65 people representing about 45 different organizations, including educators. We have capitalized on the opioid crisis. Some of the people we've got involved are the coroner's offices and the law enforcement around the opioid issues, because they're aware that many opioids are prescribed for the treatment of chronic pain. Last fall, almost Christmas actually, we had a deliberative dialogue coordinated by John Lavis's group at the McMaster Health Forum, creating an evidence brief and laying out basically a one-page summary strategy for how to proceed. Some of the people in this room participated in that, but we also had a variety of other pretty broad-based groups participating. You've heard about Pain BC. Quebec is about 8 years ahead in terms of developing provincial strategies. They have a research and clinical care strategy. And most remarkably, last week, as part of the opioid symposium in Toronto, representatives of the chronic pain patient community as well as the research and clinical care community met for the Federal Minister of Health for 2.5 hours. That level of interest is unparalleled. But we spoke about the issues to do with chronic pain and the importance of federal leadership, and have now been asked to prepare a document to describe what the national coordinating body would look like that would drive this strategy forward. And that's what we plan to do, to look for initially for a national coordinating body. That's the small ask, aiming for a big ask that's proportionate to the size of the problem. And you've heard that the problem of chronic pain far exceeds many other problems which are identified with very substantial funding, both from a research standpoint as well as a clinical care standpoint. And these are some of the people. Obviously, the business of looking a long way on the shoulders of giants is not a trivial statement, but these are people who've had a lot to do with how we develop the strategy. So I think that's it.